Hi, I'm Laurie Hanin. I'm the Executive Director at the Center for Hearing and Communication. And it's my pleasure today to be talking to Dr. Tom Roland. Dr. Roland is the Mendick Foundation Chairman of the Department of Otolaryngology, Head and Neck Surgery at NYU Langone Health, Professor of Otolaryngology and Neurosurgery, and my particular honor that he is also CHC's Medical Director. And I've known Tom for many, many years, and it's a pleasure to be able to chat with him a little bit today. So Tom, this past year has seen incredible challenges in the world and medically. How has COVID impacted how you treat and manage your patients over this past year, or has it?
Well, firstly, Laurie, thanks for the introduction and thanks for having me. It's always a pleasure. And as you know, I've enjoyed a very long relationship with the CHC. Maybe too long than we want to remember, but
Never
30
too
some
long.
years. So yeah, it's been an interesting year. You know, if we go back over a year ago when all this began last February, and then the onslaught of patients, you know, our hospital was completely full with COVID patients, over 1,000 patients, ICUs, ventilators, PPE, all those things were in shortage. And so we've basically had to shut down elective care. So we had to then decide, you know, what was important, what wasn't important. There was issues of safety to staff and doctors and healthcare workers, and there was issues of safety to patients. Could a patient even come into a hospital and safely have something done electively or be evaluated and leave without catching the disease? And we didn't know a lot. And over time, we started putting in safety guidelines. We have filters in the room, HEPA filters that circulate the air every 5 minutes. We put filters in the suction machines that we clean out ears with. You know, everybody's masked up, the rooms get wiped down, patients get tested before they come, all the employees are tested regularly. And over time, probably about by May, when the hospital started to open up again and they realized that we could do elective things and start to see patients electively again, we started opening up, and very nicely. And I think with all these safety guidelines in place, it became a very safe place to come for care. Unfortunately, you know, hearing health wasn't considered urgent or emergent, when the two of us believe it is urgent and emergent because that's what we deal with all the time. And I think those patients suffered a lot. Patients weren't coming in for cochlear implant mappings and tune-ups for evaluations. And I think by now, you know, by towards August, September, I think patients felt comfortable coming. They realized it was a safe place to come with all the safety guidelines in place. It was a safe place to come for elective surgery, like a cochlear implant, which is an outpatient procedure. And it was a safe, safe for the staff and faculty. So I think now we're pretty much up to full speed. The most recent little surge in New York didn't get that big. You know, I think last count, maybe we had 107 patients in our 3 NYU hospitals, maybe only 40 in ICUs, and which is much better than thousands and hundreds. So I think we're now able to provide safe, quality care. Interestingly, the bounce back was greatest in our hearing impaired population. I think these were the people that were suffering with mask wearing and everything else and communication. And it may even have nudged people that were on the edge of deciding whether to get a cochlear implant or a better hearing aid to actually do it, because they think they're having more and more difficulty. So I think that's probably been the positive side of it, that patients that maybe were contemplating holding off or waiting or let me see, or maybe it's not so bad, are beginning to realize that with masks especially, it makes life so much more difficult for communication.
I think that we're seeing that a lot here too. Now we've heard reports and read some things about COVID actually causing hearing loss or sometimes tinnitus. Can you tell us a little about that, and if you think that's a real thing? What's been your experience?
Yeah, I think it's a very real thing. You know, there's physiologic and medical reasons why it can cause hearing loss, especially, you know, some of the very, very sick patients that were in coma and intubated got potentially toxic medications for life-saving reasons to fix pneumonia, maybe had hypoxia, you know, low oxygen levels. All those things can affect the inner ear and hearing. We have had one extreme is patients waking up from comas and being totally deaf in one ear or both ears. We have a recent patient that you probably know about that had that exact situation. He was fortunate enough to recover, but he was very, very sick, and he just received a cochlear implant for single-sided deafness, which is an indication that's approved now. We had to fight a little bit for it, and he's doing quite well. The nice thing about a cochlear implant in single-sided deafness, that besides improving hearing, it also suppresses tinnitus in almost 90% of the patients. And some of the patients say to me, well, the hearing is great, but the fact that this noise in my head is gone is fantastic. I might even have done it just for that. So, there have some patients that have both ears are down. There's a lot of potential medical reasons. And I guess the big question is, does the virus itself get into the inner ear or cause problems with the inner ear? I think the bulk of what we know from autopsies and other things, the main sort of pathophysiology is that COVID virus attaches to platelets and causes micro aggregates, which then cause the micro blood vessels to clot, so like a lot of mini strokes. So for example, people are having heart attacks that never have coronary artery disease. People are having brain dysfunction and strokes that never, aren't even in high risk groups. So you could imagine, the only blood vessel to the inner ear, the cochlea, is a very tiny vessel off another vessel near the cerebellum, the cochlear artery, and so it wouldn't take much to occlude that artery and cause low oxygen levels and no nutrients and no nourishment to the hair cells in our cochlea. Fortunately, the nerves still work, and so they do benefit from cochlear implants. I would say, if I had to guess, and from reading literature, it's underestimated how many people have some significant or some hearing loss from COVID. Probably many aren't even getting tested because they have other major issues that they're still dealing with. This sort of post-COVID syndrome we've been hearing about. People are affected for months, the brain fog, the malaise, all those things they're working on. But I think it will probably bear out that, yes, it probably does have a direct effect on the inner ear from that microcoagulation, I suspect. And also from, the medications that one had to receive to save their lives might also have an effect on the inner ear.
It makes a lot of sense the way you explained it. Do you feel, has it been that it's mostly people who have the more severe COVID who end up hospitalized that you're seeing with hearing loss, or can it be a milder case and they also experience it?
I think the ones with profound hearing loss that lost all their hearing and might be a cochlear implant candidate, probably yes. It's probably those that had real severe cases, which is why it's a complicated thing to figure out exactly what caused the hearing loss. I don't think we know about the mild hearing loss. I don't think we have long enough testing. I don't think maybe we should just institute anyone that's had COVID should get a hearing screen, and might not be a bad idea. At some point, along the way, the practitioners, providers should just include a hearing test, especially if they're complaining of a new tinnitus or trouble on the phone or all those things that we know indicate there might be hearing loss.
So you kind of answered my last question of what recommendations you would give to somebody. So same as anything else, really, we need to listen to all of our patients. And if someone is complaining about hearing loss or tinnitus, get a hearing test.
Yeah, one thing you can do in the electronic medical record, they ask us every single patient, we have to ask about your BMI and being overweight or not, and sleep apnea. We have to ask about smoking and smoking cessation. We have to ask women if they've had a mammogram, all these sort of routine healthcare things that we're supposed to be doing. We're trying to get them to include hearing loss in that. I think it would be great, because then every single provider, whether you're a medical doctor or a pediatrician, might ask a question or two, a screening question about hearing loss, and then that would pop up in the EMR and remind them to go get a hearing test, go get checked out. And that's a way we can use our electronic medical records in a very positive way for routine healthcare. I think it has great, we're working on that right now to have that as our system is called EPIC, which is the electronic medical record probably most commonly used in the country. And one nice thing about it, that if you travel around the country, you can see things in EPIC from other medical centers. So you can see what's been done and have a complete healthcare record. But why not just incorporate that as a pop-up? Did you ask your patient about hearing screening? Then you have to respond to that. You can say yes or no. And if you say no, they ask you why not. And if you say yes, then would you like to refer the patient? You can click another button. So just 2 clicks of a button, you could encourage someone to get into the pathway for hearing health.
That would help so many people. I mean, all of the older adults, especially that don't really treat the hearing loss, it would open up a lot. So I think that if you can make that happen, anything we could do with you on that, we're all for that.
I think it's a great way to use some of our digital technology in a very positive way to have more patients have access to hearing healthcare.
Well, that's great for that. Thank you so much. Thank you so much, Tom, for your time for this. It's been very interesting, and I know that it's going to help answer a lot of questions that we've been hearing.
Thanks, Laurie. Thanks for having me.